The Adderall shortages are real. They're episodic in terms of pill size and duration. It's been going on since summer, and I don't see any indication that it's going to be over within the next 2 or 3 months. Take-home message is that there are limited options for how to deal with this, but I will try to highlight what I think they are and also discuss some of the problems and consequences. But I'm going to start with, why is this happening? Aren't we a civilized, industrialized, computerized world where we can track supply chains and make sure everything that's important for a population is available? Part of the answer is this is a simple economics issue of supply and supply and demand are out of sync. Lots of the articles I've read have focused solely on the increased demand. I'll start with that, but I will get to there is very clearly actually the critical and starting point of this, I would argue, is a supply issue. So what's the demand issue? The demand issue is that prescriptions for Adderall, including generic products, amphetamine-containing products, have increased dramatically over the last few years, primarily or the largest within the 22 to 45-year-olds. So looking for the 4 years, 2018, 19, 20, 21, where we have complete data during 2020 and 2021, the number of prescriptions written each quarter of the year, so 4 quarters of the year, each quarter went from a baseline of about 1 million to 1.2 million by the end of 2021. So that's a 20% increase in 2 years. The 22 to 45-year-olds are the largest part of the amphetamine Adderall market, so much bigger than even the 45 and over and much bigger than the kids market. Although more kids are being treated for ADHD than adults, the majority of kids are on methylphenidate or Ritalin-based products. Prescriptions written for Adderall for kids actually decreased a tiny bit. And the increase for the 45-year-olds actually also increased substantially from about 500,000 per quarter prescriptions written to about 600,000. So that's not negligible. There's been a lot written about that increased demand, and clearly COVID is one factor or one part of it. But if you look at the numbers are going up substantially 2 years preceding it. So we're not working from a stable baseline. So COVID cannot explain all of this increase. Part of that increase beforehand is that there has been ongoing awareness of ADHD in adults over the last 2 decades. That's still increasing. And while some people condemn it and say this is horrible, and the fact that we are prescribing more stimulants is proof that we are overprescribing, I would argue the data show actually the opposite. And that is the number of adults in this country with ADHD vastly still exceeds or substantially still exceeds the number of medicated individuals. So we are still at a society-wide level undertreating ADHD, and the evidence is still pretty compelling that the most robust, consistently effective approach for reducing ADHD symptoms still is stimulant medications. Now, they clearly have problems and issues, but again, the fact that we're prescribing more is not in and of itself a sign that we are overprescribing. I'm not denying there may be individuals in that group who shouldn't have been on the medication or were inappropriately prescribed, but I would argue the numbers overall, if you look at how many adults in this country have ADHD, are showing that we are still underdiagnosing and undertreating ADHD. Of the articles I've been looking at, some also blame this increased awareness and increased popularity of stimulants on TikTok. Now, I'm not denying that it might affect some people and influence. I don't know that majority of prescribers are getting their guidance from TikTok. Actually, if you look again over the 2 years of 2021, 2020, 2021, the age group that is most locked into TikTok are the 21 and under group. Their use of Adderall actually declined slightly. Boogeyman or villain that's been singled out for this rise in stimulant, particularly again, Adderall prescriptions, is the telehealth world, and particularly companies like Cerebral and TruePill. Both of them have faced charges that they were essentially pill mills or encouraging their providers to overprescribe stimulants, to do hasty and inadequate evaluations. And again, clearly there are individuals who got medications or started on stimulants through those systems who probably should not have been. But how much of that increase in 2021, 2020 are due to those companies? One, again, you're showing some increase before 2020, and the steeper increase, I think, preceded any substantial market penetration by Cerebral or any of the other telehealth companies. So I'm not saying there's no role there, but I do not think that we'll be able to parse out and show that they were a major culprit in this. Looking at the other side of the question, the supply side, and here, if we're going to label people villains, which I'm happy to do, Teva, the biggest generic drug company in the world, and in this country, far and away the biggest manufacturer of Adderall and generic Adderall products, has been Teva. Teva is the sort of immediate cause of the shortages. So starting in the summer of this year, 2022, sort of belatedly, they acknowledged that they were having manufacturing issues. They weren't willing to pay higher wages to enough workers to get the product out the door. And some of it were problems with actually packaging, containering rather than manufacturing. Many of the drugs in this country that are generic, there are as many as 10, 12 different companies all making generic versions. So the active ingredient has to be the same one, and they have to roughly follow the same bioavailability in terms of how quickly it goes into the body and how quickly it reaches peak levels and how long it lasts in the body. I started with saying that this process is likely to continue for some time, is that Teva, in my opinion, has a particularly bad track record in terms of demonstrating that they care what happens to patients and all. Maybe with this bad publicity rising from the Adderall shortage, maybe they'll be more responsive. But what I cite is very recent history. There is a antidepressant we've had around for a long time. It's called Nefazodone. It is a unique drug in that it's the only drug in its class working particularly on serotonin 2A and 2C antagonism. So it has some weak serotonin reuptake, norepinephrine and dopamine reuptake action. It is not primarily an SSRI or SNRI. It's been around for years. Bristol Myers Squibb stopped making the brand name more than 20 years ago because there were some deaths from liver failure. Even the critics of this drug, which forced it off the market in several European countries, have never demonstrated a rate of deaths from liver problems greater than about 4 deaths per million. That's horrible and tragic, those that happen to. But for many of our standard antidepressant and non-antidepressant drugs, rates of 1 out of a million deaths from liver failure are not unusual. In fact, are fairly common. This rate, again, was somewhat higher, but not an order of magnitude higher. It's only been available as a generic for 20 years. For many years, there were multiple makers, but for the last several years, Teva was the only maker of it. They were sort of opaque, but suddenly in the August of 2020, they stopped making Nefazodone. Again, patients who were on it had absolutely no recourse, no similar drug to go to. And despite many requests from federal agencies, as well as desperate patients and doctors, Teva was very opaque about when they were going to bother producing it, what the actual issue or shortages were. And it took them a whole 16 months before they started producing and making Nefazodone available again. I have not much faith that Teva is going to do much better in this situation. They clearly seem to be an American corporation. By that, seem to be valuing their bottom line rather than doing right by their clients or the community at large. Controlled substances like Adderall face tight restrictions in this country in terms of how much is manufactured, how much each pharmacy is allotted. It's the DEA. There are federal mandates that determines that. The shortages we're seeing now of Adderall do not seem tied in any way to the DEA screwing up. So one is that the DEA has fairly limited leverage. Again, they do allocate how much total amount of each controlled substance can be made. They do assign each particular allotments to each of the manufacturers that have applied for the right to make that in this country. They also do regulate how much product can be delivered to pharmacies, and the amount delivered to each pharmacy is dependent on historical prescribing by that pharmacy and what that pharmacy has on hand at the moment. So if they have a big excess, they're not given extra shipments. But there do not seem to be problems with the allocation or the DEA restrictions and allocation process. So the DEA does not have the power or authority to unilaterally say, too much Adderall is being prescribed, or as many people ask them to do, too much opioid, too much oxycodone is being prescribed. Let's cut the supply 20%. That's not, the DEA does not have the authority to do that. If a certain number of prescriptions were written the previous year, they have to at least continue at that allotment. So the DEA is a branch of the Department of Justice. FDA is a branch of the Health and Human Services. It's the FDA whose job is sort of to monitor drug supplies and shortages. And they are actually pretty slow and behind the ball. So even though early August, patients in newspapers reporting shortages of Adderall, it wasn't until early October that the FDA acknowledged the shortage. And although in San Francisco, I've been seeing substantial shortages of Concerta, which is methylphenidate-related product, in the last 2 weeks, I've not seen the FDA officially acknowledge any Concerta shortages. Moving on from what's caused it, what can we do about it? So one thing to be aware of, again, this is not a global all production shutdown, none of it's available. This is the companies, Teva and others, are trying to make as much as they can, but they have limitations. On a week-to-week basis, a given pharmacy may or may not have 5 or 10 or 20 milligram dosages. So if they tell you your size is out, and they may not volunteer this information, the first thing to ask them is, do you have other dosages of Adderall available that my doctor can write for? Now, unlike with some non-controlled substance where if you had a 20 milligram pill size, the pharmacy is allowed to substitute a single 40 milligram pill if that's what's available and that's biologically equivalent. With these controlled substances, they are not allowed to make that substitution. So you will need a new prescription from your doctor, but that's often the fastest, quickest way to get it. So I've had patients who are on 30 milligram pill and the pharmacy let me know or them know that they still had 5 milligrams in stock. So even though they needed 6 times as many pills of the 5 to equal 30, they could fill it that day, that time at the store. And in this metropolitan area like San Francisco, there have been many instances where one Walgreens had it, the Walgreens didn't have it. The pharmacist may not be comfortable sharing that information, but there, at least in California, are not any legal reasons they cannot. I mean, they are allowed to share it. They may choose for company or personal policy reasons not to share that. But it's worth asking them because that can save you a lot of running around. They may be allowed the 10 milligram immediate release, but it's worth asking if they have the extended release or switching back and forth. Now, again, legally, they are not allowed to substitute by themselves. They need a new prescription, although I've seen in a medical journal reports by doctors who document that their patients were switched between immediate release and extended release by the pharmacy. Clearly, that was illegal, even if they were trying to be helpful. Third option is substituting for a different product. Now, the difficulty here, I know everything I'm reading and many of the ADD experts say people do get different results, or some do. But if you're having trouble with Adderall, just switch to Ritalin. That's pretty good. They're both stimulants. My view of the evidence, my clinical experience, is that Ritalin's more closely comparable to Strattera, Wellbutrin, duloxetine, all of our non-stimulants than it is to another stimulant. So we are not talking two comparable stimulants. We're talking Adderall amphetamine products here and all the other options a second choice. Again, it may be a good choice for you. Again, some people even get better results, but looking at extent of improvement or reduction in ADD symptoms and the percentage of people respond to them, amphetamine-based products outperform methylphenidate-based products. So this is really a good time to work on improving sleep, improving exercise, improving diet, working with CBT and behavioral approaches to improve scheduling, reducing distractions. And a significant one that I recommend that for some people, this might be an important time, bring up the topic of accommodations or to acknowledge your ADHD in the workplace. I do have another video on workplace accommodations and how to talk about your ADHD at work. You should not be viewing or framing it to your employer that an accommodation is a company's sacrifice to compensate for your deficits. Because what an accommodation really is, a request they be flexible to help you maintain your productivity. So I usually call them efficiencies rather than accommodations. That's something to ask for. In terms of the consequences, there's a big article on Wired talking about the Adderall withdrawal crisis and that this is going to kill lots of people because one withdrawal, and again, withdrawal is not a fatal condition. It's usually short-term from the stimulants and usually negative mood and negative energy. Most people recover within a few days. But their bigger concern was lots of people are going to go on the black market, get meth and other bad drugs. I'm sure that will happen at some individual level, and that's tragic and horrible. I don't see any epidemiologic evidence yet that this is a crisis or dramatically increasing. We do know that after each opioid epidemic in our country, that there's been a stimulant crisis following in a pattern, and I wrote about that, as did others, 4 or 5 years ago. We're seeing increasing evidence that even before this Adderall shortage, there is more problem with street stimulant abuse. But the bigger cause of death and misery isn't going to be withdrawal. It's going to be the lack of benefit of stimulants. And we know that people with ADHD are more at risk for a whole host of accidents, starting with car accidents. And these include fatal and seriously injuring accidents. I do think people will be dying without their ADD medications because ADHD is a serious condition, but I think many more of them are likely to succumb from accidents and a lack of the benefits of their medication rather than from withdrawal or rather than substituting with more dangerous medications.